You need no introduction, but the founder CEO of Essen Health.
It was totally bootstrapped, and when I look back, I wish I was smarter. I think our model is meant for urban areas, underserved and dual population, Medicare and Medicaid patients.
And so you have 29 different specialties you serve today. You have house calls, but you also have urgent care, you have primary care, you have nursing homes. To Medicaid, it's a very hard population to serve from a reimbursement perspective.
Dealing with the poor reimbursement, I realized that to fight insurance denial rates, to get prior authorization was the simplest thing. So I set up a back office that will bring some support for billing. There is a lot of opportunities for US and India corridor.
Hello, Dr. Sahgal. It's such an honor and privilege to have you with us. Thanks a lot for your time. You need no introduction, but the founder CEO of Essen Health, and you built an incredible organization that I've had the good fortune to know a little bit from the outside. This episode, we wanted to have folks learn from your decades of work, physician leaders who are looking to start and build their own companies, for founders interested in healthcare, for large healthcare companies trying to innovate.
You're very kind and generous in your introduction. Thank you, Pankaj. It's a pleasure to be here.
Thank you. Maybe just for the audience, a few lines on Essen would be helpful, a good starting point.
Essen Health is an integrated delivery system which provides care in the life cycle of the patient. When they are pediatrics, when they are adults, when they can come to the office. We have offices, and if they can't come to the office, we have house call, they need access to care, we have urgent care, we have all the specialty in our health system. If they go to the hospital in the Bronx, we follow them in the hospital, in the nursing home. So it creates access to health in every aspect, and the key is to provide the best quality care in the communities we serve. And the communities we serve are typically underserved community and elderly population.
You grew up in India, and then you decided to move to the US and did your residency and training. I'd love to learn more about the origin. Yep.
So I grew up in a middle class family. My father is a professor, a retired professor of chemistry in a local college in the University of Delhi. My mother was a housewife, 2 sisters, a brother, and I was the youngest. Okay. And I wanted to be an architect. And my mother said, I have 2 engineers and an architect, you should be a doctor. And in my first year of medical school, my mother died because of massive bleed on her head. Because she wasn't taking care of her blood pressure, she wasn't taking her medications regularly. So it sent a shock to the family. And I think that part of that event really molded the rest of my life. So my father had studied in US and he encouraged me to go to US for further training. And anybody who knows New York back in 90s, it was a tough neighborhood. As with any foreign graduate, we get into the toughest hospitals, and most good hospitals are in tough neighborhood. And that's how I started.
I'm really sorry to hear about your mother. How did that event shape some of the work that you did?
So when I started practicing, it started in Far Rockaway. I go to the nursing home and I found young people in their 30s and 40s, similar to what my mother had, had a stroke, had an MI, they are now disabled. Back in India, yes, we have dearth of resources and education. How come in this country, which is supposed to be the best healthcare in the world, how come these people have this? And then I realized that we spend so much money and resources in acute treatment that there is a need for primary care and preventative treatment. And then I realized, how come the system is not focusing on it? So that's where I put myself for education, and I joined a master's program in the evening school at Wagner School at NYU, which is the non-for-profit arm of NYU. And that's where my journey started.
How is it different, the training as a physician in India versus the US?
Both systems train amazing doctors. It's a great training, intense training, but they train these doctors to come out and practice in their own ecosystem. The ecosystem in India is a little different. It is high volume. It is the British School of Medicine where clinical examination precedes anything else. So we were trained in that school. In US, it's high quality and diagnostic testing take a precedent to find the exact cause. Coming here gave you a very specific training, and moving into practice, you have different environment of practice. Like in India, it's hospital or office. Here we have hospital, we have office, we have nursing home, we have urgent care centers. So it's very well defined. I think India has evolved over time, but here the innovation always stays ahead in healthcare.
And then you ended up in the Bronx. People always think about the glorious parts of entrepreneurship. You worked 3 jobs. You worked from 5:30 in the morning, so probably woke up at 4 a.m. in the morning. I'm sure you didn't get home way after dinner time. What was going on at that point in your mind? Because I'm sure it was fun. It was good to take care of patients, but it was a lot of hard work. After 2 years of, completing your visa obligations, you could have found a nice cushy job somewhere in Long Island. What made you continue 14, 18-hour days as clinicians?
It's a great question, Pankaj. I think one is the circumstances which allowed me to do it. My wife would let me do it. She was busy, but obviously it's a sacrifice on her part and the children. 2, I saw so much good being done with my work and work of the team, where these patients which would not be able to get access to care or, the right treatment, we could keep them out of the hospital. It was Bronx is one of the toughest environment to work in. It's one of the poorest congressional district in the country. It's got a poverty rate of 50%. It is one of the highest, it's actually the asthma capital of United States, one of the highest rate of asthma. And, there's always a physician shortage. It's got like 1 physician for every 2,000 people, as compared to New York City, which has 1 physician for 1,000 people. And if you look at the United States, that ratio is even lower. When you see the results of your, of your hard work translating into good care, and then you see more opportunity. So I didn't have any blueprint what I'm going to do. Plus, you had to figure out the environment factors in the Bronx. But, when we looked at it, the joy it brought to the patients, feedback it gave me, why the patients are not getting better. They weren't taking their medications. They were sitting there for years. So they needed to be told which is the medication they need to take and which is the vitamin or supplement they can avoid. So within every year, we grew 100%. So from those 40, 80 patients, now almost 20 years later, we have over 24,000 patients that we are doing house call for in 5 boroughs of New York City. We have over 100 practitioners that go every day. We do almost 1,000 visits a day. And they have drivers, they have whole scribes, they have a whole central team that supports them. And over 400 patients that live at home are over 100 years old. So if we didn't provide these services, they won't be able to live at home. They will be living in nursing homes. And, we have contracted with CMS, who now gives us the sickest people, the most costliest people in United States. And we have demonstrated cost savings, improved quality. It gives us the innovation that allows us to do better care of patient.
That's incredible. Just going from 40 patients or 80 patients to 24,000 patients. And this is maybe 20% of the business you built,
yes.
Right? And there's so much more to that. Going back to the early years, at $7.50 a visit, what would Medicare or commercial pay at that point?
Medicare would pay around $80 to $100.
Wow.
And commercial will pay double of that, 150 to 100.
It was 5% of reimbursement. How did you make it work?
Multiple jobs and just keeping and just having faith that system will change. But also that's why the hours were long.
Yeah.
But in 2003, actually Medicaid changed it, and for office they decided to increase it to $30 flat rate. No matter how sick the patient is, just $30. And then within a year or so after that, managed Medicaid came in. So managed Medicare started paying at a better rate, a percentage of Medicare, 50 to 70%. So that actually helped started floating around, some of the revenue and some of the overheads we were able to do. Yeah. So yeah, my first office I had, it was a hole in the wall. Yeah. We had no sign. There was a big hole on the waiting area. So, whenever it rained, we had a bucket that we collected the water in. And one of my patients actually told me, you have the worst office on the Grand Concourse, but I love coming to you because you're such a good doctor. And it was the best compliment I got.
That is incredible. That is incredible. So when did this become a real business, not something that you had to cross-subsidize by just putting in more hours? Like, when did you feel that, okay, maybe this is something real, right? We can actually make a high-quality, financially sustainable business?
It's a blurred line because every time one division became better, I had another idea to follow.
Yeah, and that doesn't change even today. It's the same.
Yes, because you see the patient needs and say, how do you innovate? I think the house call probably was the toughest one. Yeah. We didn't break even until 15 years into the into operation because it's just a very unique model.
And you were building all of this bootstrapped. You never took money from anyone until recently.
No, it was totally bootstrapped. And when I look back, I wish I was smarter. So Bronx became our living lab. Yes. We got a lot of wisdom from living. We failed in a lot of things. So I wish I could say that I started doing this. It was just amazing. Yeah. No, a lot of things got broken while we were doing this, and we got stretched. Yeah. But we learned from our experiences, and we then built up system that helped us cover the week. So we had to upgrade our phone system, but we were without phones for half a day. Yeah. We learned that lesson. So, things broke down, and we had a call center, and then suddenly call center started expanding so fast that we had to then figure out how do we divide and conquer within the various operations. And I think that's where really our secret of success is. Yeah. Our tenacity to serve the patient. Yeah. Keep in mind that we want to provide the best quality care.
Yeah. Patients show up when they feel valued, when they feel that they're getting the care. It doesn't matter if there is a leaking ceiling. The house calls didn't break even for 15 years. What gave you the resilience, or what made you continue that? Because in all common wisdom that we would tell our founders is, shut what's not working in a couple of years and you give this 15 years. Why?
I saw how important it was for this invisible population in United States. So there's an invisible population we don't see, people that are homebound. And they're not homebound just because they're elderly and have chronic disease. There are a lot of young people also that are homebound, morbidly obese, having severe disability, including, complications from diabetes. So this is a population that was not seeking care. And I realized that if we stop providing care to these people, then it would just violate the very principles that, make us physicians and practitioners. And also, frankly, deep in my heart, I also believe that one day this is going to be discovered and somebody's going to say, wow, that is just amazing.
What I'm hearing from you is over the years, you were receptive to what patients needed, and you built a model that seemed to work for everyone in a very, very resource-constrained environment. And so you have 29 different specialties you serve today. You have house calls, but you also have urgent care, you have primary care, you have nursing homes, you have chronic care management programs, and you're serving patients where they are versus, look, I'm a 1,000 provider primary care group and that's all I do. You're basically building a holistic care model for the community, which is a very different way of building a local, privately owned business in healthcare.
I stumbled upon it, let's put it this way. Stumbled because I came to this country. I was on a J1 waiver. So I had to come to and work in the Bronx. And, events happen that define us, like you related your life journey. And Bronx is 40 square miles. And, unlike Westchester and Long Island, other areas, it's got 1.5 million people, a population of 35,000 people living in 1 square mile. Long Island, Queens is 3,000 people per square mile. And with that density, most people don't drive.
Yeah.
They take subway, buses, just no place for parking even.
Yeah.
So, we were able to, innovate and put 45 locations within one location, within any mile of any patient.
Yeah.
And as we did this, we added more services. So I really believe in one site model care. So if you're there, you should have a primary care, you should have a fast track or walk-in or urgent care center. So immediate access can be given, which we do with 7 days with our urgent care center. And there should be specialty care. So within a certain reasonable distance. So we are able to do that. In the last 1 year, we actually realized that our patient needed more preventive care. And one of the biggest challenge we felt was that people are not getting access to mammograms for breast cancer screening. So we got 2 mammogram units, and then while we're doing it, we established a whole radiology unit because the other folks said, hey, how about CT scan, how about MRI? So we started with 1 each. Now we got 3 CT scanner, 2 MRI. And then our cardiologist said, people go for coronary angiography to detect, stenosis and blockages in the heart. Technology exists. We can do this as a CT scan, coronary CT angiography, and we can do cardiac PET scan for better detection of heart disease. Said, sure. We added that software in the same machine, and now we are doing hundreds of them in a year. And we found that 13% of our screening program actually turn out that they have a blockage in their heart, and they end up going to the hospital to get a stent placed and actually avoid heart attack and damage to the heart.
No, that's incredible. I think, when we're surveying doctors and we're talking to them, both in India and the US, the use of generative AI solutions was like 5 to 10% last year. It's 75% this year. 75% clinicians use generative AI solutions almost on an everyday basis today in India.
Wow, in India.
And obviously in the US as well. Our role as healthcare innovators is to make that safe. Because of hallucinations, but the models are getting better every single day, right? You mentioned 12 times better in the last year, and probably 100 times better in the next 2 or 3 years as they proceed. So tell me a little bit about your vision for technology and AI for Essen, and maybe let's even start with what are a couple of examples of problems that you're solving even today with technology and AI that have made it better in the last few years.
Initially, everybody in healthcare assist technology. In early 2000, electronic health record system came in. 2008 is when we adopted electronic health record system. It took a little time. And one of the biggest problem technology has is technology is a victim of their own success. Now, there were multiple call centers, agents, we had hundreds of them actually. And we said, how do we know the quality is good or not? Like we can't monitor hundreds of people at the same time. So there's a quality assurance process, but then now we are partnered with another company called Pop AI. So they run in the background of our call center software, and the AI listens to the conversation, and actually then at the end of the day is able to give a report to the supervisor. So once that happens, we are able to now improve patient experience, patient engagement. So that's one part we are doing. We also are creating this platform with this amazing company, Reveal MedTech, which is actually now going to be integrated with our electronic health record system. So that way we can actually generate reports for our clinical leaders as to the complexity of illnesses, the need for follow-up, following the protocol for complex disease, whether controlled or not, as well as for operational leader, and also create a plug and play for these agentic AI.
And I think the power of what you've built over the last decade, you understand and have tracked so many different patient personas and patient journeys in the millions longitudinally. And you're sitting on millions, sometimes tens of millions of data points that are unique to the Bronx, but at the same time are applicable to many such neighborhoods throughout the country, right? So your call centers are operating 1 million calls a month. Your urgent care, your primary care, your house calls are dealing with patients with multiple chronic conditions, and so there's so much of good high quality training data to then build agentic AI solutions or use best-in-class market agentic AI solutions to your setting. Every 2 months, there's someone knocking on your door saying, let's bring this to Rhode Island, or let's bring this to Texas, or let's bring... What are your thoughts about the Essen model? What of this you want to scale up outside of New York?
I think our model is meant for urban areas, underserved and dual population, Medicare and Medicaid patients. That's our expertise. And that is where our learning curve has been. For example, Newark, Philadelphia. And, they're very similar demographic to what we have. Chronic disease, high density of population, lack of resources, access, high disease mortality, morbidity burden. But I think the hardest to do is primary care. So what we would love to do is partner with primary care practices, which are typically small or fragmented, and provide them the whole integrated delivery system with them in the center, or work with certain specialties so they can scale and expand early diagnosis, treatment.
And technology and AI will help you identify, engage, provide the right intervention, a lot of that much more effectively than with humans in the past.
Yes, AI-assisted humans.
Of course. So you want to bring some of these capabilities, your technology care model, multiple specialties, outpatient work, to different geographies, which are urban, serve underserved communities in partnership with local, primary care practices, almost like a provide additional services in an asset-light kind of MSO kind of model in different parts.
Absolutely. So we have a large behavioral health unit. We started this a few years ago, and we are an underserved community. So we deal with a lot of mental illness, some serious, some mild to moderate. So we recently partnered with a company called CareForce with their behavioral health unit. We were already looking to do transcranial magnetic stimulation and treatment for our patients. And this company has an expertise on TMS. We said, sure, we want to use your expertise to help build up. So this is a treatment where you actually have a patient sit down with a hairdresser-like helmet, but they are getting magnetic waves. Of course, you have to qualify, you have to have a certain right patient, but basically what it does is for these patients is it basically reboots some of the nerve fibers so that it helps with serious depression and help with the medication. So we started doing this, and we already look at the demand, and we realize that much more units are required. So it allows us to partner with this company to expand this across the community and other areas too. So these are the innovations and partnership that we really like.
That's incredible. And bringing into a community like the Bronx, where less than 1,000 patients have access to TMS, and probably the need is 100,000 patients or more. I think we've spoken, or you've hinted at some secret sauce of success for Essen over the years. It's incredibly inspiring. Most of it, a couple of decades or 70% of that completely bootstrapped before you took on capital from outside. You mentioned frugality a few times as a guiding principle. You mentioned compassion and hearing your patients and your care teams a little bit. What are some of your additional secret sauces of what have made you successful?
I may differ in my opinion about some of the verbs and the nouns you used. We did as a team. Nothing incredible. We want to do it more of it that way. So I appreciate the kind words. Everybody has to look deep in their heart and find out what inspires them, what motivates them. I think if somebody is motivated by money, which many people do, it's not a bad thing. We live in a capitalist society, but it is not going to take you to a level where you're going to change things in the world. It's not going to be transformational. I saw all these people who could have prevented the diseases, where doctors could have diagnosed them early, but they missed. So the other part is, my biological father died when I was 3. So the doctor didn't diagnose him right, gave him an enema. Turns out he had appendicitis, he had ruptured appendicitis, he had peritonitis, he died. Doctors have a very important role to play. But that after coming to this country, after started practicing. And I realized that there was an opportunity to change people's life.
This is our second episode. And in the first episode, when we were talking about the journey of Narayana Health, another very inspiring group, that when I asked about the secret sauce, surprisingly, the answer was exactly the same. Is that the power of purpose transcends everything, right? When you are in this world, in this line of work, there is no joy above doing right for patients and doing it at scale. And if you do that, a lot of other things fall in place. And thank you for sharing a lot of what drove you to build this company over the years. If you could go back in time 20 years, 25 years, and share a couple of pieces of advice for a young Dr. Sahgal, what would you share knowing what you know today?
Don't be full of yourself.
Okay.
Nobody invincible. Seek help, seek advice. And that's what I tell everybody. Don't try to do everything yourself.
Yeah.
Get people who have done it before and take advice from them. Just lack of access to people who have done it before.
Yeah.
Because I was in the Bronx.
Yeah.
But I was very fortunate to have Professor Tony Kovner be my mentor. Amazing teacher, great mentor. And one of the things that he always did was he made you uncomfortable in your shoes. So first time I went to her advice when he says, write it down, send it to me. And then I realized over time that when people write things down, it clears things in their mind. And that's what his whole purpose was. I thought he was trying to shoo me away. Yeah. But I realized, no, he actually read what I wrote and then he came back and sat with me. And then one of the best advice I got for Tony was, I actually was thinking I'll do masters and then I will actually do MBA. Because, MBA is the thing to do. But I did get accepted to a few colleges, including Stern Business School, Columbia, and, I was on the wait list for Columbia and University of Michigan. But with this letter, I went to Tony. I said, Tony, I got this admission and I was studying there. I said, what do you think I should do? He says, what do you want to do? Yeah. Do you want to be a medical director for a healthcare plan? I said, no, I don't like those guys. He says, then just finish your master's, get the experience, and do what you want to do. You want to change the way healthcare is delivered. That's what you said before. Yeah. So I said, oh, that's true. So I went back. I just finished my master's and I stayed local. That was the best advice I ever got. So those are the things that, people have to figure out is the passion, the skill sets, and where do they really want to go? And sometimes you just have to wait for the path to open in front of you.
Yeah. Now, having the good fortune of spending more time with you and your team through different projects and seeing you operate, there are a lot of special traits. I think one of the most endearing thing about you can also be the most annoying thing about you is that you're extremely impatient. But that's a superpower because you can see what will happen 5 years down the road. You can build conviction and make decisions, knowing that most decisions are reversible. And you are impatient. You want to do what is right for patients. Yesterday, when you spoke to me about TMS, it was just a couple of months ago. You're already seeing patients, right? And being able to translate and act very quickly, act with conviction, act with leadership, and outwork everyone, right? I was joking with someone from your team. I'll send you an email at 11 p.m. in the night, half expecting anything, and 11:03 I get a response from you where you don't have to do that. It is just the passion driving you to continue to make progress and continue to do better for your teams and for your patients. So what does a typical day for you look like? How much of your time is in running the business, thinking about the future, and then how much of it is taking care of patients?
Not enough time with taking care of patients. Given a choice, I would spend my day taking care of patients because it's the most gratifying thing. At the same time, my team needs more guidance and help. And, and as they come with innovative ideas, they want to use my past failures to bounce those ideas to see how they put themselves to succeed. A big part of my day is spent, with the clinical divisions, chalking out strategies for early detection, diagnosis, and treatment. What can we do in women's health? What service can we bring? Like I told you about coronary CT angiography, that started with a thought just earlier this year, and it's already implemented. There are certain treatments that we felt the community needed, like allergy testing because of the asthma rate. So that's being put in place. And since my team and I have done it, so it just becomes for us to become a guide post and a pillar to bounce their ideas off. And then, of course, we just don't put things in place. We have a certain workflow process where we actually then measure every part of it, do a key performance indicator, then see is it achieving the purpose and the goal. So one of the books, Measure What Matters, has an amazing insight. So I encourage people to read books to increase their skill sets and their thought process.
Switching gears a little bit, you convinced your wife to come and work at Essen. She's a surgeon, and you somehow managed to convince her to work at Essen. How did that happen?
I won't go into the groveling, the begging, and the kneeling that went into it. So my wife is a breast surgeon, and she's was practicing in Westchester. And I've been asking for some time that I need somebody to come and take care of my patients with breast cancer. And I can't get appointments for my patient for 3 months in the hospital system. So my patients started going to Westchester. Because those who could, and she felt so bad about it that why am I making patients come from Bronx to Westchester? So she said, okay, fine, I'll come once a week. So she would come once a week, once in every other week. And that's how she started. And then when she started coming to us after a period of time, my CFO and my compliance company manager, we have a problem with your wife. So what's the problem? Well, she doesn't pay rent. She comes and sees patient, and we're doing all the billing. She's kind of a little bit of a freeloader. So we acquired her practice, made her an employee, and so I work for her now.
Well, that's incredible, and she is such a powerhouse. Like having spent some time with her, and the passion that she has kind of mirrors your passion as well. When the kids were growing up, Shreya and Nisha, both of them got engineering degrees, and they didn't go to medical school. Was that by design? And then both of them are now working in different parts at Essen, trying to continue to build the future of Essen. So how did that come about?
Change by design, I guess. We would have liked them to be physician, frankly, but unlike being told by our parents that we need to be, kids need to follow their heart. They got involved in robotics early on in school, and both were captain of the robotic team. Both were convinced they want to go into computer science. We were very lucky that they actually found their passion, that they want to use technology to bring healthcare better, to bring a change in patients' life. And I think that's what motivates them. They work with some of the generative AI companies, with Reveal MedTech, with CareForce, with other companies. And they then look at which are the points of inflection, pivot points where technology can make a difference in patients' lives. And that's where, I think in some ways they're carrying our passion and legacy of changing people's lives.
What are your personal goals for the next 5-10 years?
After we survive the apocalypse of generative AI in the next 5 years, all of us will have a struggle to keep us relevant professionally. So I would like to keep myself relevant for healthcare and the changes that are coming in. My other passion really is workforce development. And just to give you a little background, so I'm an international medical graduate, and I was lucky I came with an education, and I was lucky that I came to the Bronx and found my passion. There are a lot of people not educated or not getting access to education. Our health education system, I believe, is as broken as a healthcare system. And there are a lot of international medical graduates that have years of experience in their country, and they come here looking for opportunities, and we are not able to tap their experience and their passion in clinical care. They end up sadly sometimes driving Uber or working in odd jobs. Some of them get lucky and they get a master's and they work in administration.
Yeah.
So I want to really change the healthcare in the community by bringing a force. So I actually approached Dr. Georges, who was the chair of nursing at Lehman College. And she took me to the president and she said, he wants to send these doctors to the nursing program, become an RN and become their nurse practitioners. And that's what we did. So we have a workforce development program. We actually send people who are unable to get into residency into an RN program 2 years, then a 2 years NP program. So from $18 to $20 an hour, suddenly as a nurse, they're making $40, $45 an hour. Then they go into NP and suddenly they're making $150,000, $200,000 a year. So it's not only is changing their lives, it is having a ripple effect on their family and on the community. So every year we graduate 10 to 15 NPs, 10 to 15 RN, they go into NP programs. So we have affiliation with local colleges, with online colleges. And now we have expanded this program for CASAC worker, community workers, substance abuse, alcoholics, and we have expanded to our medical assistant for sonogram tech, and also for LPNs, licensed practical nurses. So we are looking, so my passion would be that I get more involved in educational programs. So maybe just for healthcare, but maybe overall change in education system.
That's incredible. And it does a lot for their families. You helping IMG's transition into high quality, meaningful jobs that will serve communities is fantastic for them, fantastic for the community, and honestly very good for business, right? Because they're motivated to stay, they're loyal.
And they become leaders. So our leaders, actually, many of them have amazing story. Before they came to us, one was a salesperson in a furniture store, and his choice was to join us or become a manager of the furniture store. Fortunately, he joined us. He drives a Corvette today. Another one was teaching maths to 5th grade, and he said, this deal sounds too good to be true, but he still kept faith and jumped in with us. He's medical director of our primary care practice now. So, those are inspirational stories, and these people are inspiring the others. So I really believe in the principle of pay forward. Today we do things for people, but we are doing it because somebody helped us in the past. So we are paying it forward.
The one thing that you've constantly mentioned around is, working fairly closely with the community. And with that comes working closely with the government, both local, also affecting policy change in areas like Medicaid, which are now under stress. How have you seen your role and Essen's role over the years in working and making sure that you're able to work with both local as well as national government?
We haven't directly involved with ourselves with, policy decision, but we work with organized societies, Medical Society of the State of New York. I am the chair of their IMG section. Our chief of ENT is the president of Medical Society of New York. Many of our doctors are involved with the Bronx County Society. I've been the president of County Society. I also am a board member of the Board of Medicine for the New York State. Those are areas we have involved ourselves to influence what should be done, not only for changing the policy, but for better care of patients. We actually recently set up a division for government affairs. And now we are, with all these changes, we feel obligated that we work with our elected representative to make the voices of our patient heard, their needs heard. So that's something we just started recently, directly being involved. We do have a non-for-profit that started with workforce development. But during COVID, we realized that we are living in a food desert, and there was a food shortage. So we started doing food distribution. So we distribute tons of food a year right now. I think in last year we distributed about 80 tons of food. So we also work with our non-for-profit with community-based organizations to look at their need, because I know what we are good at, but we really know what we are not good at. So some of these CBOs already have an expertise on helping patients in the community, education, immigration. So we support them and we work with the CBOs to then serve the community.
And Dr. Sahgal, like coming back to Medicaid, it's a very hard population to serve from a need perspective, but also from obviously from the reimbursement perspective. And reimbursement rates have increased over the last few decades, but not that much. So how is it that you manage not to stay afloat, not to only stay afloat serving patients with Medicaid, but actually thrive? Whereas the general wisdom says it's very, very hard to do. And the data says that anyone serving Medicaid is going to be in the red.
Yes, the initial year were a struggle. Again, lucky because I got a contract from the nursing home that kept the light on, also allowed me to expand to other nursing homes. So over time, we started building up more Medicaid patients, not just Medicaid. So if you look at our divisions right now, in office, 60% is Medicaid. In house call, 90 to 95% is Medicare. Nursing home, mostly Medicare. So I didn't make the rule, but I followed the rule. And I realized that, the fragmentation in healthcare system is also reflected in the fragmentation of payment. When I started my office, I was a medical director in a federally qualified health center in the hospital. For every patient I saw there, I used to get paid $250. I moved to private practice. I did the same care. I would pay $4.50 or $7.50. So having that insight also allowed me to understand the Lego pieces involved in healthcare. So I could build a system that was not only financially viable, but created a huge value for the patient. And I think over time, programs came out like Obamacare. It was amazing program for us because it brought ACOs, Accountable Care Organization. So we jumped into ACO. What happened is that there are a lot of support, social service organization funded by the state that support the poor people. So in 2013, the state came with a health home and they basically consolidated every organization and said, you as lead health home now have to have people under you, care management agency that will serve these people with whatever you want to do with social determinants of health. And you will reduce the unnecessary hospitalization or ED visit by 25%. We put our hat in the ring. So what happened is that I could look at and say, oh, you know what? Maybe that's a good opportunity for us. There's an opportunity cost. The risk I took, the opportunities I got lucky that I kind of beat the odds and was able to get a team together to serve the community in Medicaid and dual population.
No, that's fantastic. Has India played any role there? Like the India-US corridor, have you been able to leverage that?
Yes, big way.
Okay.
Because we have a back office in India. Dealing with the poor reimbursement, I realized that to fight insurance denial rates, to get prior authorization was the simplest thing. And realizing that most insurance companies have their back office in India, many years ago, I set up a back office that will bring some support for billing. We are able to now, get care for our patients at a little lower cost. There is a lot of opportunities for US and India corridor. If you look here, the CEOs of major tech company, many of them are Indians. We have an amazing tech, talent back there. Now, we have to be careful that we don't take opportunities away from people here. At the same time, if the cost becomes unaffordable and inaccessible due to cost, we have to find innovations. And that is where the opportunity, I think, is.
Absolutely. Absolutely. We've had the good fortune to partner with you on CareForce. I'd love to learn your vision for CareForce and how you see that panning out.
I think it's a tremendous opportunity to help a lot of organizations to scale. As much as I believe in primary care, and I'm a primary care physician, I think many of the chronic disease need specialty, intervention and support for primary care. And to scale specialist, especially with technology, is so much needed across the country.
Yes.
CareForce, with its founders and the team, is able to look at certain areas like behavioral health. And I think they're working on other models and an MSO light model, managed service organization, which allows physician to control the practices and the quality of care that they really want to deliver while getting support, because, not too many physicians have the ability to put in costly cybersecurity system, costly technology solutions. And in this evolving world, operational efficiency will play a key role in survival of private practices. And I think CareForce is going to play a major role and a very important role for these practices.
No, absolutely. And for us, driving force has always been that it will help bring much needed services, clinical services that are not available today to patients. So improve access, improve quality, but more importantly, help independent practices stay independent and grow without having the financial resources of a much larger group. And I think it fits that kind of mission as well.
And there's one more point. That CareForce, looking at the team, they are very smart, but more importantly, they're always innovating and learning. So I think the lessons they learn from one part of the country can be transferred to another part of the country to make care better. And that's the beauty of an MSO Light program.
Well, this is fantastic. This is a masterclass in healthcare innovation. Thanks to Dr. Sahgal. It's been truly inspiring to see the organization you've built, the work you've done. You continue to inspire countless people like us as physicians who need role models like you to look up to and continue to build.